It's the AEMT lecture series. Welcome back. This will be, excuse me, this will be titled Test for Review, because I've been having some computer issues and my computer's not accepting a lot of graphics right now, basically. So I'm trying to keep it plain and simple. All right, but let's talk about our upcoming test and what you need to know and that sort of thing. So let's talk about the respiratory chapter first, I guess. Let's talk about congestive heart failure. Well, before we do that, let's talk about what respiratory means. So defining respiratory means it's the exchange of oxygen and CO2, at that cellular level. Okay, that's what respirations mean. Okay, so understand that. Also, when we talk about congestive heart failure, we always want to associate lung sounds and rales to congestive heart failure. There's a couple of definitions that are kind of mentioned in your book that are important to understand. One of those is cardiogenic, pulmonary edema, cardiogenic, CHF. All right, so cardiac asthma. So all of these are related to the same physiology as of pulmonary edema. But a lot of times they'll throw on cardiac asthma when you have like a high-pitched wee sound that's coming from that. Sometimes the fluid is so bad that it affects the bronchioles, and the bronchioles actually do constrict a little bit, causing that wheeze. So we need to remember when we're assessing a congestive heart failure patient, we're assessing for that nocturnal dyspnea, right? Remember what that is. If the patient's lying flat, they can't breathe. They can breathe better when they're propped up. They can breathe better in a sitting position. Talking about cystic fibrosis, know what that means. That's that excessive thick secretions that are built up, excessive sodium loss causes that. Remember when we're talking about anaphylaxis, that upper airway swelling is part of anaphylaxis. Remember pulmonary emboli. All right, we're talking about folks who usually it's from not usually, but one cause of that is from being in a prolonged fixed position. So maybe you've had some type of surgery and you've been confined to the bed for a couple of weeks. That allows that blood in those lower extremities to kind of clot and causing maybe like a DVT or something to move up and causing a pulmonary embolus. So emphysema, what is it? Emphysema, remember, it affects the alveoli, right? It's usually from damage to the alveoli. It's usually, we can relate that damage to the surfactant. When we have, when that surfactant is not there anymore, and remember, surfactant actually keeps those alveoli open, okay? And it increases surface area. So when you don't have surfactant, you don't have that increased surface area, and you can't keep the alveoli open. The brain. Remember, the brain provides a stimulus to breathe, and in normal folks that are healthy, it's carbon dioxide, right? But emphysema patients, they have that buildup of carbon dioxide, and they end up switching over to reading O2. Patients with COPD and emphysema are also suspect to pneumonias, and that's the reason why is they can't get the air and secretions up out of that alveoli because they're damaged, and that eventually can lead to that an infection building up in the alveoli. So they're very suspect to pneumonias. when you're trying to, maybe you have a patient that has pneumonia, and you're trying to determine the difference between pneumonia and COPD. Well, that pneumonia patient will have that, we call it pleuritic chest pain, okay, but, so can the COPD patient. Bronchi, well, CHF patients can have bronchi too in pneumonias, but usually fever is in pneumonia, okay, because it's about usually bacterial infection, usually pretty prominent fever. And so that usually, if they have a fever, you can kind of rule out between COPD and emphysema. All right. Remember, we talked about that RSV virus. RSV virus can bring on bronchiolitis. Remember, that's found in children, and it can cause pneumonia. So how do we fix a tension pneumothorax? Well, we can, a lot of times we can't fix it in our scope of practice, but we can call for a paramedic unit to do a needle decompression. An IV, maybe, maybe I won't fix it, but it's not a bad idea. Ventilations, managing the airway, providing ventilatory assistance. Yeah, that's a good idea. But we don't fix it with medications. I mean, you just can't. The patient may deteriorate, go into cardiac arrest. But until we fix that pneumothorax, all the epinephrine, all the drugs in the world will not help that patient. All right, so when we're talking about assessing a patient in respiratory distress, we need to know that when we reach that point of altered mental status, that means that, hypoxia at that point in time is affecting the brain. All right. So hypoxia affected the brain, altered mental status, inadequate breathing. We've talked about this in EMT school, and we're talking about it again. It's not just based on the respiratory rate. Okay. I mean, it gets our attention when the patient has a respiratory rate of 24, 26, right? But doesn't necessarily mean that the patient's in respiratory failure. If we add 26 breaths per minute, and we say that the patient has poor chest rise and fall, then we can say the patient's in respiratory failure. All right, so at the end of the day, it comes down to chest rise and fall is a big indicator of the failure, if the patient's in respiratory failure. Remember, pulse oxes, they can be inaccurate, right? They can have CO can replace hemoglobin, and the pulse ox won't know the difference. It's still going to show 98%, and your patient's, going to be in serious trouble. And then we need to think about the treatment for these patients in respiratory distress. If we decide to go with like a breathing treatment, we need to remember the dosage of your albuterol, 2.5 milligrams. Remember your side effects. The side effects of albuterol. Remember tachycardia. It can cause a patient to be nervous, shaky, stuff like that. Okay, so we talked about respiratory. Okay, let's move to the next chapter. Give me just a second. All right, let's talk about the GI chapter, okay? When we're talking about signs and symptoms of a serious hernia problem, okay? So, we need to know that because hernias are a common occurrence. I've seen some bad looking hernias, really have. They're not always life-threatening. Matter of fact, I would say most are not life-threatening. But there is a time and place when they can become threatening. And so in your book, it lists a few. I would know those, and I would know that, if you see red, bluish discoloration, that could be bad. If we had a hernia come in and the GI doc came in, the specialist, to reduce that hernia, and they literally just come in and mash it right back in. If the GI doc can't reduce that hernia, then that becomes a problem. Then it's off to surgery. So know those. When we talk about peptic ulcers, right? Peptic ulcers can ulcerate. They could cause bleeding, and sometimes that bleeding can be profound and can cause shock. We need to understand that so that we can prepare in case we're treating a patient for shock. When you're palpating the abdomen, always remember to palpate that opposite side first. So if it's left lower quadrant, or let's say if it's right upper quadrant, you're going to palpate the left upper quadrant first, and then move your way over that way. If we have a peptic ulcer that's bleeding, right, and that patient is in shock, an IV bolus would be the treatment for that patient, but we're just providing enough fluid to maintain perfusion, okay, until you get out in the field and fall under those protocols. Then you'll have an exact dose, but until that day, or they're already out in the field, but you know what I mean, till you become an advanced provider, then you'll fall under the advanced provider protocols and you'll get an exact amount of fluid. But really, all fluid, even when we're bolusing patients in the field, the goal should be just to maintain perfusion. As soon as we get a radial pulse, then we should slow that fluid down. All right. When we're talking about peritonitis, read about peritonitis and understand what causes peritonitis. There's a couple of definitions in there. They're not definitions, but it's in that paragraph. It's going to tell you what peritonitis is, and it's going to tell you what causes peritonitis. Understand that, okay? Because that's important to know. Know what your function of your small intestine is. Know what your function of your large intestine is. What the function is. What does it do? So this, a lot of times when you're trying to associate an acute abdomen, and let's say those of you that were in lab this week, we had a scenario where you had a patient with an appendicitis, right? Always see if they have a fever, okay? Because a fever can be associated with an appendicitis. Okay, if you have someone who has an ectopic pregnancy, okay, female ectopic pregnancy showing signs and symptoms, understand what your treatment for that is. Okay, a lot of times these patients will be normotensive, okay, and their blood pressure hasn't dropped yet. That's okay. We still need to provide immediate transport for that patient. We need to treat for shock. Don't forget that you're going to be an A now, so your treatment for shock is going to be a little bit more than just warming the patient, okay? This patient's going to require, some form of a, an IV maybe. So, hey, understand that. All right, so now let's move to the next chapter. The next two chapters are kind of similar to the endocrine system, and when they talk about diabetes as well. So, common causes, patients with hypo hypo and hyperglycemia, excuse me, is an altered mental status. A lot of times a patient has, extremely high glucose reading or extremely low glucose reading. You will be administering, D50, or, I know our protocols here are changing to D10, but on the national level, I think D50 is still the go-to thing. And so you're being, you're testing on competency at a national level. So D50 will more likely be always, your treatment, what you'll find, to treat diabetes for. Instead of D10, you're going to see D50 is what I'm trying to say. But anyway, we need to make sure before we give that D50 that IV is patent. Okay, and what does that mean? Well, IV being patent means, one, that it's flowing. We can see it dripping, and we can see that it's not infiltrating, meaning the skin, we don't see fluid in the subcutaneous. We don't see, a big bruise rising up. And so it's really important, because D50 can cause tissue necrosis. And that's one big reason why we went to D10 here. Know what your factors are when we're talking about hemophilia. Know what those factors are, like factor 8, etc. All right, stand by 1 second. Reach around me here, grab some more. All right. So another treatment that you'll be providing as an advanced provider is glucagon. Okay. And so what does glucagon do? Well, glucagon can release that stored sugar found in the liver, and can bring the blood sugar up, but it only works if those stores haven't been used yet. The body will use those stores. All right, so if that patient's been in a diabetic coma for a while, those stores are probably going to already be used, but you can try it. Know what glycogen does. Glycogen, just know what it means. I'm not going to tell you what it is, because you can look it up. All right. So know what glycogen is. Know that what glucagon does to glycogen. Okay, glucagon does something to glycogen, and know what that is. Know what that is. So this goes back to EMT school. And so I gotta review it, I guess, right? Because sometimes we forget. I would hope you wouldn't forget this one, though. We can't give oral glucose to someone who is what? Unconscious, right? We can only give oral glucose to someone who can maintain their airway. If they can't maintain their airway, then we can't give it. All right, and so then we can talk a little bit about transfusion reactions. So if you go to the hospital and your hemoglobin's really low, they're going to say, hey, you need a blood transfusion. And so what they're going to do is they're going to draw labs, and 2 of those tubes are going to go over to the lab, and they're going to what we call do a type-in screen. They're going to find out what blood type you are. And so let's say you're A positive. And so what they'll do is they will type and screen that blood, and they will call me up and they'll say, Mike, your blood's ready. And I'll go, okay, great. So I'll trot on over there to the blood bank, and I have a form, and I say, okay, and we confirm this. I'll say I have patient XYZ, date of birth, his medical record number is, and I'll say that it's AB positive, let's say, or A negative or whatever, right? And that form I have, the other person will read it back and we'll compare. And then we're looking at the blood too, and we're making sure that between me and the blood bank that I have the right blood. Let's say something happens and it's the wrong blood. You can have what we call a transfusion reaction from that. And it's when you're provided with the wrong blood type. And it's we watch it when we're giving somebody blood every 5 minutes. I'm checking their vital signs, and it includes a temperature. And if for the first 15 minutes. And so if anything changes in there, what I'll do is I'll stop the blood, and then I'll flush it with saline, and then we'll give them some Benadryl. That usually fixes it. Well, we don't see it very often. All right, so know what insulin does to the cell. Okay, it facilitates something. Tell me what it does, or know what it does. Okay, know how glucose works with the cell, and know what insulin is too. What does insulin do? Okay, know that process. Know when you would see Kussmaul respirations. What does it mean? What does it look like? What can when you have diabetes, what can you not metabolize? And it's what is a cell? What can it not metabolize? How do we treat patients with hyperglycemia and ketoacidosis? Okay, so how, as an advanced EMT, do you treat them? So what is their problem? Their problem is they have a extremely high elevated blood sugar. Okay, they're going to be dehydrated very badly, and they're going to have an electrolyte nightmare going on too. So, but besides that, and as an AEMT, how are you going to treat that? Know how to treat it. Know what the signs and symptoms of hyperthyroid is. Okay, so you have hypothyroid, you have hyperthyroid. Know what those signs are, and know what a thyroid storm is. Okay, it's in your book. I even put it in one of those little boxes for you. So know what that is. Know what glycolysis means. Okay, know what glycolysis means. Know what a type 1, type 2 diabetic is. You should already know that. Please pray tell me you do. I was in EMT school. You got to know glucagon for this test. I'm already seeing that. You've got to know what glucagon is. So you got to know what it does. So know what happens when that blood glucose is high. What is the body going to do? How does the body react to high blood sugar? Okay, so I know I'm going to have excessive thirst. Okay, so I'm going to be drinking a lot of water. So what's happening? What's going on? Let's see. Know what Wildebrand disease is. All right. If you went to EMT school here, you'll know this. If you didn't, you may not. Because I know, especially if you were a student of Gravea, because I used to hear him harp on this. But the brain, right? the brain doesn't use something for the uptake of glucose. So know that. Okay, so know that the brain depends on somebody else, I'm just going to say it. The brain doesn't use insulin for the uptake of glucose. It depends on the rest of the body to send it glucose. Again, know what Kuhl's breathing is. You got to know what insulin does. Got to know. Okay, know what type 1, type 2 is. Seeing a theme. All right, know what an antigen is. Know how the body responds to that. And know, let's see. Yeah, you don't need to know anything for that one. Know what your dose of epi is, and let's see. Just know what your dose of epi is, and I think I'm not going to tell you about this one. You should know this one. But you should know this one. I'm going to leave it. All right. That's it. So that's your review. I hope you guys watch this. I have a bad feeling I'm going to say, hey, did anybody watch that review video? And they're like, no, I didn't see it. But please watch it because it'll help you. And hopefully I'll get this video thing worked out. I'm fixing to go talk to the man in training, Chief the Man Roberts, and see what the plan is here to fix this so I can get these videos out to you guys. All right, guys, and good luck tomorrow. I'll be looking forward to seeing y'all. And until we see each other tomorrow, have a great day.